Well, hello, good afternoon. I think I can start. I have that here in my phone. So, hello everyone. My name is Isabel Florzalen. Thank you for your time. Thank you for your attention. And I really hope that you enjoy to pass with me these 2 hours. Please, anything that you want to ask, I'm completely open to answer to all your questions. Okay, so I'm going to talk about predictability on a clean check. So from the clean check to the clinical reality. I'm from Oporto, the second town in Portugal. It's in north, and it's a beautiful city. Well, it's my city, of course, but it's a beautiful city, as you can see. And this amazing bridge was the same of Gustavo Infeld was the guy who do this project. So we don't have Paris here, we don't have the Eiffel Tower, but we have something about Gustavo Eiffel here in our city. So if you want to visit us, well, you are welcome. Well, I study here in Oporto. I do my post graduation in orthodontics also in Oporto, my master, and I have the pleasure to be with Dr. McNamara in US in Ann Arbor, Michigan University. And well, I do everything. Well, I will do braces in edgewise technique with tweed foundation, sado sato with a multi loop. Then I work with Damon system, and I start doing Invisalign in 2014. And in that time, everyone said, "Well, Isabel, you are crazy. Invisalign doesn't work. How you can imagine do that? You have the master, you have your post graduation in orthodontics." And for me, it was a changing of all my practice. But well, looking now back, was the best thing that I could already done. I've been also with Dr. Christian Coachman in Brazil for 2 weeks with the SD residency. And well, now we work, we want to do some conference, and it's amazing to work with Christian. And well, these are my three idols: Dr. McNamara, Dr. Cruikshank. I already have the pleasure to be with Dr. Cruikshank and Christian Coachman. This is my clinic here in Oporto, in very center of Oporto, and well, we have everything. We have, so we work with implants, with novel implants. We do the GBT airflow. Uh, so I need to do Invisalign. So this is a full. We have full work in digital workflow, and it's the best in my opinion. So, and the best of the best is our family. So this is me, my husband, and my two twin daughters with 2 years and a half, and we go inside our presentation. So this slide is not my slide, it's a slide from Invisalign. And you can see that Invisalign said to us that only 75% of what we plan it's possible to achieve in the mouth. Okay, so when Invisalign said this to us, we must do something in the clean check to increase this predictability. So that's why I'm going to talk in these 2 hours. And if any of you have a tip at the end of this webinar, I will be very pleased about it. So I'm going to talk about clinical cases. I have lots of clinical cases, and I need to introduce this patient. This is my first clinical case, and as you can see, the extra oral photos, I have it, and as we can see, we have the midlines are centered. Main patient compliance is the upper lateral incisors are inside, and this is an orthodontic retreatment. Well, the upper and lower midline are centered, class 1 molar bilateral and half class 2 canine bilateral. Okay? So the treatment goals in this case is the class 1 canine, retroclination of the incisors, and alignment of the upper, main patient compliance, and of course to correct the lower incisors. And how we can achieve this treatment goal in a Clincheck planning? It's my question. And in this type of treatment, what will we do? We order an Invisalign i7, we order a light, or we order a comprehensive Invisalign. Well, if you were all together, I will ask to raise your hand who do I7, who do light, or who do comprehensive in this case. Of course, by that goes correction of the class 1 and everything. Well, I will go for an Invisalign light and I will show you what happened in this case. This was the first Clincheck that I received. And you can see that we only had 9 aligners from 14 and the class is not completely correct. So what I asked was, please overcorrect the rotation of the teeth in the first quadrant and put me the 13 in a perfect class 1. If needed, please do IPR. And I received this second Clincheck. Well, if we only look to the first quadrant, well, we saw, well, every tooth are moving at the same time, and you say, well, this Clincheck, it's a crazy one. It's impossible to achieve that. But if you look careful in the occlusal view, we saw that this is not a distalization, but we are doing a derotation of the whole quadrant. Okay, and here we achieve 13 aligners. In my 3D controls, I asked to add button cutouts in the 6, in 46, 47, and an attachment to create anchorage of an horizontal attachment on the 45 and on the 47. And I have the new Clincheck with my 3D controls, what I ask in my 3D controls. And we can see we have 13 aligners. Well, we have 13 aligners. Well, I want a 14, I have a 14 aligners treatment, and I know that maybe I will not achieve this movement. So what I ask, a mesial precision cut in the 13, and since there was still an aligner available, please overcorrect the movement. Thank you. And I receive another Clincheck with 14 aligners and with the overcorrection of the 13. And a new Clincheck model has been posted for your review. Please evaluate and indicate if you are satisfactory. And thank you, and have a very nice day. So yes, I'm very pleased with this Clincheck. I'm using the class 2 elastic not to achieve the class 2 or not to do distalization, but to help me with this derotation and with the derotation of the canine. So, as you can see, again, look at the occlusal face of the Clincheck, and you see again we are do the rotation of the whole first quadrant, and of course a little bit on the second, but the first quadrant is the one I want you to show. This is aligner number 1, and this is aligner number 14. My predictability here is 100%, not 75, not 80, not 90, 100%. And I will explain you why. I'm sorry. So this is the final photo. Sorry, this is the final photo. And as you can see, I start this treatment in 2019 and I finish in 2020. And if you saw the blue parts, I always do a change aligner every 10 days when I use the elastics and I use an Invisalign light. So the predictability of this treatment is 140 days, okay? But we closed the clinics due to COVID-19 and the patient placed last aligner during the quarantine, so during more 2 months. So the predictability of the treatment was 140 days plus 48. That's why I achieved that amazing result at the end. As you can see, what we programmed and what we achieve. And I think this is 100% predictability. Okay, and I achieve. I didn't do additional aligners in this patient because I don't need it. It's done. Okay, so what I want you to tell you about this case is, well, make sure if you want to use 7 or 10 days when you have a light treatment using the elastics, maybe not use 7 but 10 days and you have a more predictable movements. Okay, so this second case that I want to show to you is a skeletal class 1. It's a class 2 molar and canine, narrow arches and increased overjets. These are the extraoral photos. And the upper midline is centered. And the main concern of the patient are the narrow arch, okay? And the patient said to me that the canines are with a negative torque. The patient doesn't say it like this, but it was the meaning of the patient. Well, my canines are for inside and my smile is too short. So these are the intraoral photos. And this was the Clincheck that I accept. Well, we need to see here something. Well, I start this Clincheck and I ask on this Clincheck to do sequential distalization 1.5. Okay? So when I do that and I start doing the distalization, well, everyone knows that we start the 7. When the 7 is a half of the movement, we go with the 6. When the 7 stops and the 6 is half of the movement, we go the 5, and so on. Well, I always do class 2 elastics from the 4 and the 5th upper to the lower 7, okay? But when the canine begins to distalize, I change the elastic to the upper canine and to the lower 6, okay? So I use, the Invisalign said to us, well, you want the distalization, you only need to use the elastics when the 5 starts distalizing. Well, I use the elastics from day one, not day one. When I put the aligners, I put the attachments on the aligner number 4. So from aligner number 4 till the end, I have elastics in this mouse patient. Okay, where that is the point. I start on the 5 and 4, and then I go to the 3. Okay, so I think my predictability will be more. I have more predictability here because I'm using the elastic earlier. Okay, as you can see, I have optimized attachments, and when I change to put the precision cut, I change to an attachment, a conventional attachment. Well, that is only because I don't have space to use the optimized attachment and the precision cuts. Okay, so I need to change that optimized attachment to vertical beveled to mesial attachment to help me with distalization. Okay, so in the upper jaw, I had expansion, derotation of the sixth, and sequential distalization. All movements at the same time. It's very, very important. And on the mandibula, I have expansion and derotation of the premolars. Of course, if I expand the upper, I need to expand the lower. And it's more easy to see here. Look to the upper occlusal Clincheck and see I have expansion, derotation, and sequential distalization. Okay, I think it's very, very clear in this Clincheck, in this view. Okay, let's moving. We already see this. Well, aligner 1 for 39, aligner 5, and here you have how I use the elastics from the 5 to 7, okay? 12 of 39, 24 of 39, 30 of 39, 36 of 39. Why I didn't use the 37, 38, 39? Because was aligners of overcorrection. And I don't want to overcorrect this case because I want to finish, so I don't want to squeeze the arch. So I didn't use the overcorrection aligners. In this case, I stop, I rescan, I do additional aligners, and I move on. But these are the difference in 30 weeks of 36 weeks of treatment. Look at the center upper midline, it's correct. Look, the narrow arches we correct, and the canines with negative torque, well, they are already in the place. So look the beginning and the end of the additional aligners, and here you have the predictability of the movement. You can see what we predict on the Clincheck, what we plan, and what we achieve on the mouth. Here, what we achieved, and we can see what we have in the Clincheck and what we achieve in the mouth. On the right side of the patient, the left side of the patient. Here, the additional aligners. And we pass to additional aligners. Aligner number 1 to 17. 5, 17. 17, 17, and start, and start, and start, and we can see, and a tip. Always do the functional analysis of the patient. In the functional analysis, this patient had no guides. So, if we look carefully, I don't have the cuspid of the canine. So, when I do the laterality, okay, the movements, I have interference in the seventh, okay? So, I sent to dentistry. I asked to rebuild the composite, in composite, the canine guides and the incisal edge of the upper incisors. And this was how we finish this treatment. Okay, so as you can see, we add the canine guides, and this is the front photo of the patient. This was published in a magazine, and now we are going to start another case. This is another case that I want to talk with you about it, and these are the extraoral photos, and the same. These patients have a narrow smile, an anterior open bite with negative torque in both arch, class 2 molar and canine, and an anterior open bite. These are the extraoral photos, and as you can see, the tongue is in right between in the teeth. So, intraoral photos, and look the amount of overjet that we have on this patient. A retreatment, as you can see, I have my fixed retainer in the mouth. And as we can see on a rickets analysis and several analyses, we have a retrude mandibular skeletal class 2 is a hyperdivergent facial pattern, had an anterior open bite. So everything that we saw on the photos, well, we have that same diagnosis in our cephalometric analysis, okay? And how to program this case. So let's think. We need to distalize. For distalization, we need to use elastics. But I need to distalize, but I need to intrude because I want to change the position of the mandibular. But if I use class 2 elastics, I have the elastics from the upper jaw to the mandibular. So how I'm going to intrude? So I need this movement. I need distalization and I need intrusion. So if I use the elastic in this way, well, it's not the way that I want to. I want distal and intrusion. I don't want extrusion. So, and if I put a mini implant and I use the elastics to the mini implant, mini screw, why not? Well, was exactly that what I do. So I connect the class 2 elastic to a mini screw placed in the jaw, warning above the roots. Allows me the distalization and at the same time intrusion of posterior teeth, correcting the anterior open bite and class 2. This correction of open bite is by intrusion of the posteriors because the patient has an enormous gummy smile, so it's impossible to extrude in the front. I must correct this case by intruding the posterior. Okay, so that's why I'm using this technique. So let's see the Clincheck, and as you can see, I have sequential distalization and intrusion at the same time. That's why I have a virtual jump at the end. So don't be afraid of vertical virtual jumps. Vertical virtual jump is exactly uh, while it's because of the posterior intrusion. Okay, so vertical virtual jump in an adult are completely possible to occur. Okay, and we had the power reaches bilingual of the incisors to not lose the torque during the retractions. That's why we have the power reach bilingual and vestibular, is because we are doing the retraction without losing the torque. So we put here the power reach and we do the retraction without losing the torque, okay? And sequential distalization with the normal protocol. So I use the protocol 1.5. So aligner 1 of 61, aligner 13, and you can see it here, the mini screw, the place of the mini screws. Aligner 27, and this is how I use the elastic. You can see this elastic is on the 13, but I have also precision cuts on the 4th, on the 5s. So I use the elastics on the 5s for a more vertical vector and on the canine to more distal vector. Okay, so you can change, well, you can ask the patient during the day to use the elastic from the mini screw to the 5, okay, and during the night from the mini screw to the canine. So you have a distalized vector and an intrusion vector, okay? So that's how I ask the patient to use the elastics. So predictability, it's what we are talking here. So look what happened in this case. These are the predictability. It's better in aligner 13, as you can see. It's better in the mouth than in the Clincheck. If we saw the position of the canine, it's better in the mouth than in the Clincheck. Look on the aligner 27. It's crazy. Look what happened here. Look here and look where is the class canine and look the premolar. It's incredible, okay? Why this happened? Because we are using mini screws and we are using the elastic to that anchorage, okay? A skeletic anchorage. So that's why the teeth move faster than the Clincheck. I will show you another case that the same occur. Okay, so when I do this clean check, I do the one and a half distalization because I want to see with my eyes what happened, because I know the one and a half distalization is very predictable, okay, but I want to understand what was the difference between the elastic in the lower tooth or the elastics to the attack to the mini screws. So this is the difference when you use a skeletal anchorage. Okay, so as you can see here, this is how we go in these uh, 27 weeks, 6 months and 3 weeks of treatment. And of course, now I need to mesialize a little bit the tooth. So these are the additional aligners. It's not a big deal because I have 60, 63, I think 61, and I go to the 27 aligner, and now more, I have more 20. So 27 with 20 is 47. So it's not a big deal. Even doing additional aligners, I have less aligners than the first clean check. So aligner number 1 of 20, aligner 20 of 20. It's amazing how we can achieve this. So start and um, and I think it's quite incredible how we can achieve this in so short period of time. And as you can see, how we close the bite, how we solve the overjet, and what is the secret here? Of course, is the distalization. Of course, is the mini screw. Okay, is the elastic, but is how we program this clean check. Okay, is how we do this program of the clean check. And of course we need to do the transversal also, because I know we have a mini screw there, but if you can look careful, we change a little bit the position, not a little bit, we change the torque of the corridors, so that help us to put the tongue in a much better position. So my tips for this case: be aware of all mechanics between teeth, aligners, elastics, auxiliary techniques as mini screw, okay? The positioning of the mini screws and how to transmit the use of auxiliary techniques in a clean check, okay? So um, don't use, well I'm going to use a mini screw, but I didn't say nothing to the technician and so on. Well, no, if you are planning to use a mini screw, why not say the technician, well, I'm thinking of put a mini screw, so please put me the precision cut on the 4th or in the 5 by the using of class 2 elastics, but I'm going to do the intrusion because I'm using the elastics to the mini screw. That's why I don't need button cutout in the lower 6th. So every time I use auxiliary techniques, I advertise the technician. Okay, I always advertise, even when I do buttons. I want to derotate the tooth, I want to use buttons. Well, I advertise the technician that yes, I'm going to use buttons to do this or that movement. Okay, so yes. Well, as a woman, and I hope we have a lot of women here with me today, I want to share a little bit of my workflow and how it works. Well, Here in my clinic, I have uh, two doctors in orthodontics, me and my colleague Katrina. And the only thing that I do was his first times, always with a scanner, with an Invisalign outcome, and sending the simulation. It's very important to send the simulation of the Invisalign outcome. I always present the plan and I see my patient on the aligner 15. Aligner 15 is the end of the first box. I look at the patient when we are thinking of doing additional aligners and for occlusal adjustments, and the last appointment before placing the retainers. Okay, I only do this in clinic, okay, because Katerina, as you can see in this photo, put me the IDS cases, placing and remove the attachments, do the all IPR, follows the patients after aligner 15, do the scanner to the additional aligners, do the appointment to place the retainers, do the final records, the photographs, and that allows me to, at home or here in the clinic, to make these presentations. I do a lot of virtual appointments, okay? Most of my first appointments are virtual. Most of the time when I share the Clincheck with the patient, if the patient wants, I do with a virtual appointment. And of course, I have time to do the Clinchecks, and that allows me to only work 3 days a week at the clinic. Okay, not at the clinic. I only see patients 2 3 days a week. So this is my workflow because the patient, when enter in my clinic, know that this is a team. So the patients are not mine, are from the clinic, and I said, well, you go to Dr. Magda or Dr. Caterina, Dr. Marcos. So here's how it works here in the clinic, and of course I'm happy because it's amazing, and I think all of you do Invisalign or use aligners, and our life quality, well, for me, my quality of life increased 100%. I really like my job. I really like to do what I do, and these are the women who work with me here in the clinic. Of course, I have boys, but sometimes we do some dinners to talk, to chat, to free our spirit, and this is how I work. Okay, so um, was a life changing moment when I decided to do Invisalign, but looking back now was the best thing that I do. Is the best thing. So here is our next case. Well, I really enjoy this case, and I want to show you very carefully this case because this patient came to me with a deep bite, with retroclination of the upper incisors, molar and canine class 1, and at maximum intercuspidation, and class 1 molar and canine right, and class 2 molar and canine in a centric relation with manipulation. Why I do this to this patient? Because this patient has joint pathology, pain, and already with daily medication. So I need to see very careful what to do with this patient. Well, if I program this patient, if I put an Invisalign, if 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 what I do in this case. As we can see, the upper midline is shift to the right side. the upper central incisors are inclined to the left side, the lower incisor, little incisor exposure with retroclination of the central incisors. And it's true, it's all true, as we can see in the photos. So these are the intraoral photos, and as we can see, I can't see the lower incisors. This is the panoramic, and this was the Clincheck that I approve. What we can see here, I have two protocols in this Clincheck, okay? I have the upper jaw, one protocol, which is the torque, intrusion and retrusion of the upper incisors. It's impossible to intrude incisors with retroclination, okay? It's impossible to intrude incisors with a retroclination. It's impossible to intrude tooth like this. So we need to gain torque, positive torque, then we do the intrusion and then the retrusion, okay? The mandibular, the lower jaw, well, I just need to unblock this jaw. Well, I have a conscious choice of no placement of intermaxillary elastics. Of course, we have jaw pain, okay, and no concern on the midlines. Why? Because my mandibular is not in the right position. My mandibular is in the position that the upper teeth can. So I need to solve the jaw pain of this patient, and for that I need to unblock the lower jaw as quick as possible by put anterior bite ramps. Well, here you can see these anterior bite ramps are the bite ramps of G5 protocol. So here I'm doing the upper and lower intrusion of the incisors by the use of the G5 protocol. Okay, so let's see. This is a liner number 1 of 22, and this is perfection. Why? Look, I have a class 1 on the right side, and I have a class 2 on the left side. Most of you, we will treat this as a class 1. Why not? But this mandibular is not on the right position. That's why when I do the manipulation and I saw that the maximum intercuspidation is not the same place of the centrical relation, and I have jaw pain, well, something we need to see very carefully. Maybe this is not a perfect class 1. Maybe, and maybe he's here, okay? So I had, when I put the aligner and when I have the anterior bite ramps, the mandibular changed from position, and this is what happened. As you can see, I have a perfect class 1 on the right side, and I have a class 2, half class 2 on my left side, and as you can see, the power ridges on my central upper incisors to help me with the proclination, changing torque of the upper incisors. Okay, aligner 15 of 22, aligner 90, 19 of 22, and look the difference. In the first one, you can see the vestibular part of the incisors. Okay, look the amount of torque that we achieve only with power ridges. Okay, most of you, or now we have, well, some colleagues remove all the power ridges and put vertical, horizontal attachments in these incisors, and well, and in attachments and attachments and attachments, and sometimes we overthinking in our cases, and when we saw, well, we have attachments in all teeth, and when the patient come to the clinic, well, couldn't remove the aligner because it's so retentive that it's impossible to remove. So balance a little bit, and um, believe in the system, and well, I believe in the power ridges. Okay, and this is the proof because I only use power ridge to achieve the changing of torque in this case, so they work. Okay, so this is what we have, and look, the difference. Of course, I start with the class 1 with the mandibular completely blocked. Then I had a class 2. I'm start to correct that class, only everything with the first Clincheck. And well, you can see it's 19 weeks, 4 months of treatment, but it's what it is. Look here. Sorry, here. Well, I know I finished the Clincheck without, mm, and I was not thinking of the upper of the midline. So yes, I achieve exactly the same that I have in Clincheck. I'm concerned. No, I'm happy because what I program, it's exactly what I achieve. Okay, so now I have the second phase of treatments. I'm going to do additional aligners, and let's see how it goes. So 4 months and 3 weeks of treatment. Here are the additional aligners. Of course, I didn't tell you, but the patient has no jaw pain, of course. So no medicines, no nothing. I think on the maybe 2 months after we start, the patient stop having medicines. Okay, so additional aligners. I have a perfect class 1, F class, and look, conscious use of class 2 intermaxillary elastics on the left side and class 3 on the right side. Okay, now I can use elastics. I don't have any jaw pain, so yes, I'm comfortable by using elastics. I don't know if I'm going to use the class 3, okay, at this point, but on the left side of the patient, for sure, I need to use a class 2 elastic. Okay, so center the upper midline, because the line is shifted to the right side, as we already seen in the beginning. So they are, I'm sorry, let me put again here. As you can see, we are correcting. Perfect. You see, we are correcting the upper midline. Okay, so let's see what happened. Another tip that I want to tell you. When I have a deep bite, okay, I always ask to red contacts in the posterior part from the 4th to the 7th, okay, and green contacts or without contacts. You can do without contacts from canine to canine, okay. Why? It's just to overcorrect the movement, okay. I don't want heavy contacts, it's just to overcorrect the movement, okay. So aligner 12 of 36 from additional aligners, 90 to 36 of additional aligners, 34 to 36 of additional aligners, and look at the midlines. Look at the class 1 on the left side of the patient. Okay, guides, we have it, perfect. And 13 months of treatment. So I think it's a very good case. The patient was pleased. I asked the patient to do a little bit more of intrusion of the incisors, but the patient said, Isabel, no, I'm fine, I'm okay, it's not aesthetics, my jaw, it's perfect, I don't want to change more. But even I didn't do the second additional aligners, but I think I have an amazing result here. So my next case, this is a case that I'm very pleased to show you, and it's not finished yet, but you will see why I want to show you this case. So I only write what the patient said to me: teeth shitter in the roof of my mouth, the lower one, the incisors. And these are the extraoral photos. And I have two implants in the upper central incisors. Well, why the patient came for that reason, and of course my colleague want to change the crown of the implants, okay, but he couldn't because the lower teeth are so the overbite is so big that it's impossible to change that position. And as you can see how it goes. So these are the intraoral photos, and this is my Clincheck. Well, I'm doing a lot of lower intrusion. Look up the amount of intrusion, and I'm leveling the curve of speed. I think I'm going on the right. I have IPR, you know why? I already explained. And I have the G5 protocol. As you can see, I have intrusion on the incisors and a little bit of extrusion on the premolars. Okay, this is the G5 protocol. In this view, it's crazy the amount of intrusion that I'm going to do on this case. Okay, I think again. My question, do you think this is predictable? Do you think that this intrusion will occur? It's a half of a tooth. Look, with the superposition. Let's see. Aligner 1 of 35, aligner 32 of 35, and of course you can't see anything. Here you are already saying, I think I have the intrusion done. It's not possible to see anything. And this is the Clincheck of the additional aligners. And we have more expansion because the patient needs expansion. And look now, look, this is what I achieve. It's amazing. This is the beginning. This is the beginning of my additional aligners. It's impossible to take photos of this, okay, on the lateral view because I can't remove the upper jaw, but it's impressive, the amount of intrusion. And again, with G5 protocol, and again, with no attachments on the incisors, okay? Don't overthink and put attachments in all teeth, okay? It's very, very important to have that in mind. And another thing, you have the power reach here. Why? Because the power reach, I hope you can see my arm, the power reach do torque radicular lingual, okay? So radicular lingual inside the bone. Radicular lingual is not the same as crown, vestibular crown. Vestibular crown, radicular lingual torque. Okay, so this is amazing because I put the root inside the bone. Okay, perfect. Let's see. Look what I achieved. Okay, and now we are doing just a little bit more of expansion, a little bit more of intrusion, not too much. We can already change the crowns if the patient wants. And look, this is the Clincheck Diaproof, plan number 5, day 1, okay? Plan number 12 on additional aligners, day 1. But as you can see, I do 6 treatment plans to achieve it. So I start my additional aligners on plan number 6 and I do alterations 7, 8, 9, 10, 11, 12, and I accept the treatment plan number 12. Look how we're leveling this curve of speed. This is with G5 protocol, okay? Exactly. G5 protocol was used for the intrusion of the lower incisors. But, well, we need to understand very clearly the amount of movement that is possible within Invisalign. And of course, I show you that amount of extrusion. I show you that it was almost 4 millimeters, almost half of the teeth. But when I go to the Invisalign data, what I see is this. Well, considerations. Pure anterior intrusion. The pure anterior intrusion is very predictable until 2.5 millimeters. Okay? From 2.5 and 3 millimeters, I have a moderate movement. And only when the intrusion is more than 4, I have a heavy, a difficult movement. Maybe I need a mini screw to do that intrusion. And if we go to the table of movements of the first Clincheck, what I see is a 3.7 of intrusion, 3.3 intrusion, 3.6 and 3.1. So maybe, well, I'm on the blue side of this. Blue, a little bit black, but not too black. So, well, I think it goes. And it's true, it goes. With G5 protocol, it goes, okay? So, and if it was possible to view the same clean check but with the new G8 protocol, well, I ask that to Invisalign, and Invisalign concede me that, and I have the same clean check from day one with the G8, the new G8 protocol. And as you can see, the as you can see, I have here the attachments of G8 protocol, okay? And let's see, what is the G8 protocol? Well, the G8 protocol improves the predictability in correcting deep bite because smart force activations on aligners for anterior intrusion, um, exactly the same as the G5, but even more efficient, okay? Improvement in the correction of the speaker. Sometimes when we have the G8 protocol, we have exactly a more exaggerated, we finish with a completely leveling curve for help us with this with the overcorrection of the movements, okay? And precision bite ramps was placed automatically of lower incisors intrusion if the intrusion was more than 1.5 millimeters, okay? And improve the predictability of severe crowding by using the optimized smart force attachments on the aligners, and of course, because we do a more efficient intrusion in the anterior teeth, well, the open bite reduce the amount of the posterior open bite, okay? And here we have again considerations. We have the difference between the G5 protocol and the G8 protocol. First, we need to analyze the difference on the attachments, okay? Look, I have attachments on my molars, on my sixth, and I have attachments on my fives and fours and canines in the upper, okay? Why? Because I have expansion and I need to do the control of that expansion and that torque. And on our table of movements, when we have that blue, as you can see on 16, 16, 14, 22, 26, and so on, when we have that blue part, well, we have G8 protocol there, okay? And why we have G8 protocol on the 16, 15, and 14? Because we have a translation, we have an expansion more than 0.5, so the G8 protocol is there. On the 222, we have the G8. Why? Because we have an intrusion more than 0.5, so the G8 protocol is there. Don't forget that G8 protocol is not only attachments, it's smart force directly through the on the aligner, okay? The 26, I have 0.5 intrusion and 0.6 buckle. So I have expansion and intrusion. Of course, G8 is there, okay? We can see also on the lower, on the 45, 44, 30, 43, 2, 1, and then on the third quadrant, only the 34 don't have. Why? Because the extrusion is extrusion, is not intrusion, and the buccal expansion, okay, the translation buccal is buccal, and it's only 0.2. It's not 0.5. That's why we don't have the G8 protocol on this tooth. Okay, so tips on this case. no attachments were required for the intrusion. We don't need attachments. You don't need to perform attachments there, okay? And look the difference. Look, in G8 protocol, as you can see, we have a flat curve, okay? Why? Because we are doing some compensations. I know we don't want that in the mouth, but we need to improve a little bit more, do more extrusion of the posterior, do more intrusion of the anterior, because we need to achieve that perfect curve of speed. Another thing, until G8 protocol, we don't have any attachment to the lower incisors. Now we have, okay, we have the that attachment on the lower incisors, and it could work in two ways, okay? You can have this attachment to support the intrusion of the canine or the central adjacent, okay? So you do support, you have that attachment on the lateral, and you have intrusion of the incisor and the canine. This attachment is exactly the same of the G7 protocol. G7 protocol, you have these attachments to the upper lateral incisors. And in the upper lateral incisors, they do exactly the same. You have the G7 protocol attachments to help you with the intrusion of the upper canine or the intrusion of the upper central, or to help us with the movement of the upper lateral incisor, who is very difficult to move. That's why we have that protocol. And now we have exactly the same protocol in the lower incisor, okay? So when you have intrusion of more than 1 millimeter of the canine or adjacent central incisor, we have these attachments, okay? So another tip that I want you to be sure and to be aware in this case is intrusion consumes space. That's it. Period. Point. So if intrusion consumes space, if we need space to intrusion, and more than that, we have crowding on the incisors, well, I really need space to do the intrusion and to solve the crowding. So we need to expand and do the IPR, okay? So we need to do expansion and to do IPR, as you can see here, okay? So intrusion consumes space. Sometimes colleagues ask me, well, but I don't do IPR. Well, you need to do always the time IPR when we have intrusion. No, you don't. You need to know is if you had the amount of expansion, it's okay about the amount of intrusion. And I will tell you what I do most of the time. If the system put me IPR to place IPR between the incisors, well, perfect. If the system doesn't put me any IPR and I see that I have expansion, what I do is I always pass the metal strip from distal to canine, from distal to the other canine, okay? So most of the times I talk about non-programmed IPR, okay? And is on this, it's here. Sometimes we don't have IPR who is programmed in the Clincheck, but clinically we need to do it, okay? So when you have intrusion and you don't have IPR, be very careful if you have or not the expansion, and pass the metal strip to make sure that you have space, because intrusion consumes space, okay? So let's continue with our cases. And this is another case that I really, really like. So these are the extraoral photos of this patient, and well, this is a class 1 molar. This is a class 2 canine. Anterior open bite, constriction of the arch, anterior inferior crowding, and interincisive diastema. These are the extraoral photos. And as you can see, the main concern of the patient is the inverted smile. The patient said to me, "Doctor, no one takes me serious because when I laugh, I look like a child. I look like a kid. So no one." And she has a great sense of humor, and so well, it's what it is. No one takes serious this lady because of this smile. And if we look careful, because we need to look carefully of this smile, well, we have a little exposure of the upper incisors, and we can visualize the gingiva and the negative torque on the oral corridors. Okay, so we don't see gingiva in the incisors, that's a fact, but we can see gingiva in the back. So we need to do something on this case. We need to be careful about the periodontal of this patient. As you can see, we have the tooth 42 is it's on the limit. This is the X-ray of the patient, and it is what it is. It is a skeletal class 2, hypodivergent facial pattern, big overjet, anterior open bite. Well, the normal for these cases. And this is what I programmed. This is what my Clincheck did. What I need to tell you about this Clincheck is, as you can see, I have butted cutouts on the molars, upper molars, okay? I have a button on the third molar, on the 28. And what I tell the patient was, well, we will try without miniscrew, but maybe we will need miniscrew to help us with the posterior intrusion. Let's see. This was the Clincheck that I proved. Okay. And if we look careful, I have intrusion of the molars 1.2, 1.1, 0.8 until the second premolar, which will help me with the gummy smile. Okay. On the other side, I have intrusion on the 24, 25, 26, 27, and 28. Well, it will help me with the gummy smile. Okay. I have extrusion on my 12, 11, 21, 22, and on canines. I know. But as you can see, I have extrusion, I know, but I only have an attachment on the 11. Okay, because on the 21 is 0, I have 0.1 of intrusion. Okay, imagine, as you can see, because we are doing extrusion, but this is relative extrusion. I don't have really extrusion. I only have that type of movement because I have relative extrusion by retroclination of the incisors. And it's easy to see from this view, okay? I really appreciate this view because if we can see carefully, the amount of intrusion in the posterior is not too much. Again, well, at the beginning it seems a crazy case. Well, what I'm going to do in this case, I program mini screw, well, whatever, and so on. But well, we change the torque of the molars, we change the position of the palatal cuspid of the molars. As you can see here, we are intruding the palatal cuspid of the molars, the upper molars. We are expanding and we are doing retroclination and not extrusion of the upper incisors. So aligner number 1, aligner number 11, aligner number 18. It's incredible. 18 weeks. It's completely different, the smile. Okay? This is the Clincheck for additional aligners. Well, I don't like the rotation of the 23, sorry. So I need to continue to do aligners here. And look at the 42. It's very safe to use Invisalign in periodontal cases, as you can see here. And here you have one of additional aligners, and here is 17 of 17 on the additional aligners. It's completely different, the smile of the patient. Look at how is the curve of this. And well, this is start end, but it's not true. I ask the patient, please let me work a little bit more on the 23 after see these photos. And the patient agreed and said, okay, Dr. Isabel, I know you want to be perfect, so let's go and work on tooth number 23 and on tooth number 35, okay? Is the two that I'm still working, but well, the result is here. It's an amazing case, again, without mini screw. The patient came here saying, well, I think I need to go to surgery. Of course, now we need to solve the difference in the centrals. We want to correct those black triangles, but it's peanuts. Now it's peanuts. Okay? So, my tips for this case: always solve transverse problem first. Changing torques, asking for palatal root torque. This palatal root torque, which will help you with the gingiva, okay? And it will help you with the position of the palatal cuspid of the patient, okay? Take always in consideration the patient's smile line, and if we extrude in anterior or we intrude in posterior, this is not a recipe. We need to analyze the smile of the patient, okay? And again, ugly Clinchecks for beautiful smiles. What does that mean? Maybe in a case like this, you can put the Clincheck without any occlusal context in the posterior. You can finish this Clincheck if with hard contacts in the front, and you you don't want a patient by only contacting the front teeth, but in the clean check you can say to the technician, to the CAD design, please do that, but I know that in the mouth that doesn't happen. Okay. Exactly. Finish the clinch check with posterior open bite or green contacts and very strong contacts at the anterior level to do the overcorrection. And this is an amazing tip, and you should be very carefully on this tip. Periodontal limitations present. What it means? Always make the overlap, okay, in order to understand the previous limit of proclination so that we do not have future gingival recession or aggravate the present ones. What I mean with that is, as you can see here in this is the clinch check of the patient with the superposition, and I didn't protrude 0.1, nothing. Okay, I put the mostly of the 42. Okay, I put my 42 inside the bone, inside the bone. Okay, so you need to do that. Don't do proclination. If you need, do IPR in the back as it is here. As you can see, is 050505. 050505. You need this amount of IPR. Okay, so let's move. This I have more two cases to show, and I've already see here that we have some questions. So you need, if you want to do any questions, so you do it, and then I will answer at the end. Okay, so let's go to the final two cases. Uh, this case was a very hard case. Even Invisalign said to me, Isabel, maybe it's not possible to do this case with Invisalign. It's true. When I done this case, so this is a class 1 molar, canine and skeleton. Okay, right size. I had a scissor bite and a hatch to edge on anterior bite 41 to 11. These are the extraoral photos, and you can see it here. The crown of the tooth 11 is smaller in height than the 21. We have a inter-incisive diastema, right scissor bite, edge to edge, I already told you that, and this is the panorama. So, as you can see here, we have these intraoral photos, and I can't see the 4 quadrants. I can see the canine, the 43, but I can see the others. So this is the X-ray. We remove the third molars, and these are my treatment goals to this treatment. Well, correct the scissor bite by intruding the first and the fourth quadrants. Asymmetric expansion of the lower arch, of course. Correction of the lower crowding and edge-to-edge bite. Maintain the class 1 on the left and improve the torque corridors. And how to achieve these treatment goals in a clean check planning. How we achieve. Can we think here about auxiliary techniques? You see the amount of intrusion that I need to do on that first quadrant. How to integrate them in a clean check? And I said to Invisalign, to our CAD design, to my CAD design, not mine, with anyone. Patient with right scissor bite. Give positive torque at least of 10 degrees from 13 to 17 and develop the fourth quadrant at the same time. Okay, it's exactly the same in the front. So if you want to intrude, you can intrude with the negative torque. So the same in the back. So we need to give positive torque to intrude and to be very careful with that intrusion. So intrude the right side from 13 to 17 with reference to the left side, because I need to intrude, but intrude how? 1 millimeter, 2 millimeters, 3, 4, 5. I don't know and I don't care. I want symmetry. So what I need is the same amount of intrusion of the left side, of the right side, sorry. Okay, so important, not move any other teeth during the intrusion, because mini screws will be used by vestibulary as the auxiliary technique of intrusion. After the intrusion of the teeth, continue with the development of the mandibular and posterior open of the arches. Make the lowest lower IPR, well, the minimum of IPR as it needs. Put the canines in class 1 and the upper incisors with space between them, because we will finish the case with veneers or static restorations. Okay? And imagine, after that, they sent me this Clincheck. Some movements in the Clincheck model are less predictable with the aligners alone, due to the low probability of real movement happening clinically. It was virtually not performed. Please inform. So imagine, even Invisalign said to me that this treatment was not good to do. And I only write this. Good afternoon. Please see my comments on treatment plan number 1. Nothing of what I mentioned was done. And they sent me this Clincheck. Dear doctor, some movements involved in this treatment are likely to require the use of aligned combination with additional aligner in orthodontic techniques. I know, I write that on the first Clincheck, so I really need to do what I asked to. So they do exactly that. As you can see, I have the intrusion of the first quadrant on the first aligners. I have the development of the lower arch, as you can see on occlusal view. I have a little bit of close a little bit, as you can see here on occlusal in the first quadrant, and let's see how it goes. Okay, again, give 10 degrees of positive torque from 13 to 17 first, because we need first the positive torque and then the intrusion. As you can see, I need to tell them 3 times the same thing. So it's what it is. Sometimes people say, "How? But I write one time and they don't do what I do next." Well, wrote again, ask again, say, "Yes, I want that. Please do this, do that." So ask, okay? So again, mini screws will be placed and used for intrusion. The lower arch place attachment when possible on the 45 and the remaining teeth. Please rotate the 42 more. It's not on the same as the other incisors. It's possible to not protrude the upper incisors as much, if necessarily do IPR on the lower. and I put the 3D commands and I change the attachments. Well, I think that optimized attachments are the best. As you can see, almost in all cases that you see, I go with the optimized. Sometimes I change the way I change the movement, but I will go with the optimized. But in this case, well, I need the buttons to do the intrusion, so I change too much. As you can see in this Clincheck, well, and as you can see, a line said, okay, I'm done. New Clincheck model has been posted for your review. Nothing more. You doctor are crazy. You can't do this. Well, this is the answer of the line. And well, again, since mini screws will be used, I want teeth 13, 17 to intrude at the same times, because as we know, intrusion or any type of movements with mini screws are faster than only with the aligners. Okay, so this is what I ask. And fourth Clincheck, as you can see, I have the attachments first, only on the first quadrant, because I don't need the others, and I do intrusion, intrusion, intrusion. Now I have the other attachment, is when I start moving of the other teeth, and I approve, I think I approve this for Clincheck, okay? Intrusion, 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 buttons to the attachment, attachments, beveled, in this time beveled to gingiva to help me with the torque, okay? And here it is. So let's go and let's go see how we do this case. So intraoral analysis, aligner 8 of 39, and this was my biomechanic. I didn't use more mini screws because it's about the question of money. The patients only want to put 3 mini screws. Well, and you will see what I do with these 3 mini screws. So let's go. Aligner 8 of 39. Sorry. And aligner 10 of 39. And here I don't have, you can see the eyes of the patient. Why? This is the natural head position of the patient on the aligner number 1, the beginning. And this is the correction of the head position. You can see what I do. I calibrate with the tripod of the photographic camera. So if you can see me, well, the patient is like this, the position, and I said to no, please round your head to the right, round, okay, stop, and I take the picture, okay? This is the fourth position, and look the difference. You can see, well, the head natural position, it seems that the occlusal plan is okay. And if we correct to the correct head position, the occlusal plan is crazy. Okay, so it's what it is, as you can see. Okay, and imagine this is the both picture are natural head position, start of the case, and only 11 weeks later. It's incredible because we are changing the occlusal plan the natural head position of the patient is changing too. It's very gratificant when this happens, yes? Here it's aligner 23 of 39. And again, the teeth are moving faster than the aligner. Considerations. When using mini screw for intrusion, teeth move faster than predict in the aligner. I have the same mini screw, but in a different places. As you remember, I began with 3 vestibular mini screw, and then I removed the first 2 and put one on the palatal and the other one in the lower to help me with the intrusion of the lower molars. I connect the buttons of the teeth to the mini screw directly in an elastic chain, and the patient doesn't touch any elastic at home. Just pull the aligners normally. Okay, and the button cut of the teeth 47 and 46 were not programmed in the Clincheck, but once is necessary, I cut all the aligners, okay? Well, I said, well, I think I need to put buttons on the 6 and on the 7. Oh, I don't have the button cutouts. Well, not a big deal. Just tuck, 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 cut the aligners. All the aligners, not only one, okay? But cut the rest of the aligners. You cut and you do the button, okay? So, aligner 23, and I stopped. And I rescan this patient to additional aligners. Again, considerations. Once the aligners are out of the alignment of the teeth, they will not serve as a retainer while we wait to the new aligners. So, we can make removable retainers involving molds, laboratory work, and second patient visit, or we can cut the aligners in the premolars. I'm talking about the upper, yes, and in the upper arch, place flow through the occlusal of the 7 and on the 6, and ask the patient to put a 4.5, 3 16 os elastics from the mini screw through the vestibulary of the other mini screw, so through the vestibular to lingual, and you evaluate if the elastic it's okay. Well, just maintain without pressure, okay? And that's it, okay? The elastic is placed only so that the teeth do not extrude and maintain in exactly same position, okay? So, additional aligners. Provider, continue to intrude the first quadrant. Maintain the final position referred in the first approved Clincheck. And they sent me this. And again, with my 3D controls, I put horizontal, bevel, twin incisal, 3 millimeters attachments, to help me. And here it is. And look in the occlusal, the constriction of the upper arch and the expansion of the lower arch. Yes, here, you see? Okay. Perfect. And here is the third Clincheck. okay, with some button cutouts to help me with the elastics. And as you can see, if I'm going to constrict the the upper jaw, and I'm going to expand the lower, I need to use crossed elastics. And here it is, crossed elastics. I have buttons in my lingual side of the fourth quadrant to use cross elastics. Let's go. And here it is. Well, in these additional aligners, my patient was a hero because the patient do everything I asked to do, as you can see. I asked Nuno, use a cross elastic on the premolars and use an elastic from the lingual of the 46 to the mini screw, and the patient used. He, every time I ask for a changing of elastics, the patient used, and it will be, as you can see, a liner 15 of 26. And here I'm with 3 elastics, cross elastics on 5, on 6, and on 7. Okay, as you can see. Now my vertical problem is solved. Now I have to correct the transversal problem because it was impossible to correct the transversal problem without solving the vertical problem. Okay, so that's why I first start with the vertical. Aligner 23 of 26 and my second pair of additional aligners. Look the evolution of the smile. Second additional aligners just to improve and of course remove a button and sorry, yes, I put the same attachments. And here aligner number 1, and here is the final. Already have the polish. I have the retainer, the lower retainer, and here is the first X-ray, the X-ray with the mini screw, and the roots are perfect. Initial. Here is the final. Final. Evolution. Final. And it's incredible, the difference. Okay, here on the transverse plane. Look how it is at the end. And here you have the progress of the treatment. Okay. Final and initial. And I promise this is my last case. This is a short case. These are the extraoral photos of this patient. Skeletal class 3, bilateral crossbite, undetermined molar class, bilateral canine class 1, 22 with Bolton discrepancy, and how to make the correct communication with the prosthodontics, and how to communicate well with my CAD design. Well, I need to see the incisal head edge position. I need to see the volume of the dental arch, and I need to see the smile line. of the patient. It's true. I need to see everything. Photo calibration. Who do calibration of the photos? If this was this, if everyone was in a not in a webinar but in a stage, I please raise your hand to do calibration of the photos. Look at the difference. On the left photo, the occlusal plane was like this, but the problem is the head, not the occlusal plane. Okay, so we go with the true horizontal, as you can see here, and we pass that line on the eye line, like this, and we calibrate the photo. It's not correct on the left side, it's correct on the right. And if we pass the same line to our jaw, I have my occlusal plane. Of course, I have my centered midline, and if I do a zoom of that, and if I show that picture to my CAD design, what I have my true horizontal, which is my occlusal plane, and we can see what going up, what's going down, and I have my facial midline. I know the exactly position of the upper incisors and my lower incisors. How I communicate with my CAD design with this photo? It's impossible. How I communicate with a non-calibrated photo that seems that I only need to intrude the second quadrant with the photo, intraoral photo. I don't know which is the correct line, if it's the upper, if it's the lower, or if it was none. But if I show this photo to the CAD design, if I show the torque correction, if I show the position of the incisors, well, the CAD design does not have this sensitivity unless you give that specific instructions. Okay, you need to do that. So the top midline is correct. You can see in the photo. So we need to use this is how I tell. So center the lower midline by the upper, placing the canines in class 1. If it's necessary to perform IPR, final, place the remaining place to the upper incisors in the same way from 13 to 23. And this is how I work. And look, my Clincheck goes exactly on the right position of my lines, which are so easy to do in a PowerPoint, with a PowerPoint. Okay? So, pre-ortho, post-ortho, and incisal hedge position, volume of the dental arch, and the smile line, and post-prosthodontics. 2017, 2018, and 2019. The patient is younger. Tips. Calibrate the photo with a true horizontal line. Always be aware of the initial position of the midline and relation with the facial midline, inclination and torque of the oral corridors, smile volume, and final position of the incisal edge. Evaluate the photograph at rest. Don't forget that the exposure should be between 1 and 5 millimeters of the exposure of the upper incisor. Whatever or not you have a gingival smile, of course, and the correct communication. So, how it is the correct communication with us? Well, imagine we need to communicate with the patients with that photos. The patients need to show the mock-up to the friends, to the family. We need to spoke with the CAD design, to the CAD design do our Clincheck. We need to show the Clincheck to the prosthodontist. We need to show the Clincheck to the patient. The prosthodontics need to talk with laboratory and technician to do the mock-up and to do the final work. That mock-up goes to the patient mouth. The final words go to the patient mouth. The family will say to the prosthodontist, well, I like, I don't like, I prefer. Well, you'll see, we need to work very clearly. And planning in multidisciplinary treatments? No. Planning in interdisciplinary treatments is how we need to plan. And of course, we need to plan with the end in our mind. So begin with the end on mind for this treatment goes well. So I always finish with this because I really like, so keep it simple. And final position, when you start doing a Clincheck, you first need to be sure that you like the final position of the Clincheck. If you like the final position of the Clincheck, then you pass to the staging. Okay? So, well, I like my final position, but yes, this canine it's okay. But well, it's okay how the canine goes from the initial place to the end. Well, let me see if the staging is okay. Oh, okay, this staging, I'm doing extrusion and rotation to achieve that final position. Well, I need to, that attachment is okay for the extrusion. The attachment is okay, or I need to put an attachment to rotate first or to extrude first. Well, it's how you need to think, okay? Please write this, take a photo. Every time you do a Clincheck, do with these three statements in your head. Final position, staging, and attachments, okay? This is me, this is my family, this is my girls, this is my baby girls. When they born, this is my family. I have my dog, the name is Jean, because we like it so much. They grow, here it is. So this is my contact. I'm on Facebook, on WhatsApp, on Instagram. You can write with me. So thank you very much. Here we continue at home. And spasiba. I think it's okay. So thank you very much to all. Let me just see. I think we have some question here. Do you use same tips to favorite the rotation? I mean general, just in truth and weights. I really don't have this. Removed automatic by chance. Oh, we removed. Ah, okay. So, do you use same tips to? Sorry, but I don't understand. Do you use same tips to favorite the anterior clockwise rotation. I mean, in January, you just into okay, I understand. Okay, I just understand. Well, when we do intrusion, most of the times you have the anterior rotation of the mandibular. Okay, of course, it's not easy to see that on the virtual jump because in the virtual jump it's vertical, open and up. Okay, so but we must understand that. So yes, when I want to do some rotation, anti-rotation of the anti-horarium rotation of the mandible, I need to unblock the position of the in the molar. So yes, I do intrusion and I wait, and then on the additional aligners I decide. That's why I said to the patient, well, I put mini screw as needed, and if the anterior rotation was not finished, well, I will put mini screw and I will do more intrusion to achieve that. Okay, so the other one, no status. Hi status, you are here. Okay, no, we can remove, of course. Mm, don't forget that when we have the bite ramps is because we can. Now it's 4 millimeters, okay? The bite ramps only appear if we had overjet less than 4 millimeters, okay? With G5 was 3 millimeters, now it's 4 millimeters with G8. So the bite ramps just appear if we had overjet less than 4 millimeters. And you can remove the bite ramps because the bite ramps is just for intrusion, okay? You can add the G8 to expansion, okay? And it's not the same. So you remove a bite ramp and all the G8 protocol disappeared. No, it's not the point. Okay, so I think we don't have any more questions. We are right on time. So thank you very much for your time. I really hope that you enjoy. I'm here, I'm available. Any questions, anything you can ask. So thank you very much and spasiba. Bye bye. Thank you.